am pleased to introduce Dr. Roshini Moodley, who will shed light on ways to close the gaps in maternal and child health disparities through her talk titled Innovative Solutions to Improve Maternal Health Outcomes. Dr. Roshini Moodley is a physician and a professor of practice at the College of Health Solutions. Dr. Moodley serves as a senior fellow at the Mosavar Ramini Center for Business and Government at the Harvard Kennedy School. She's a global healthcare executive and experienced practitioner with commercial expertise in healthcare, financing, risk management, population health management, value-based payment systems, and healthcare digitalization. Dr. Moodley led several transformative healthcare industry initiatives involving the use of real-time data to support workplace decision-making, innovative funding models to manage risk, and new digital technologies to create value within healthcare systems. Please join me in welcoming Dr. Moodley.
Thank you very much, Natalie, for that very warm introduction. I'm really delighted to be having this opportunity to speak with everyone at this conference. I know this has been planned and executed today in such a fantastic way. So really excited to be part of the community in Arizona to discuss and advocate and work on this very, very important topic. Natalie did give you an introduction, but just by way of her introduction, my name is Roshini Naidoo. I'm faculty at the College of Health Solutions. I mainly instruct in healthcare systems, and I'm also a fellow at the Mosavar Ramani Center for Business and Government at Harvard Kennedy School. So before getting into the solutions, it's really crucial for us to have a common understanding, but more than a common understanding, a really shared understanding of what the problem is. And it every now and then, it's really helpful to take a step back from what it is we're doing in our various vantage points in the healthcare system and really reflect on what it is we're trying to solve for. When we do that, when we do have that pause, we usually go to the data. And the data with maternal mortality is not that easy to get a common understanding of. Absolutely, we can get to the key insights and the key trends. And what we will hear consistently and what is accurate is that maternal mortality in the United States is on the rise compared to OECD peer comparisons. The US lags on maternal mortality measures. The other undisputed fact around maternal mortality involves the fact that in the US and in many other countries around the world, there are significant disparities, and those disparities play out across socio-demographic, race, ethnicity, language, geography. Once we get a little deeper into the numbers, that's really where the complications start arising. And in our different organizations, it is important. We do need to get into the granularity of the data to make certain that we're solving the right problems and that we're leveraging the right capabilities. We each have different capabilities. We're speaking to you today through an academic lens. If you're a provider, we might have a shared goal to improve maternal outcomes, but how we go about doing that and how we might prioritize those solutions will be different. Hence, again, the importance at an organizational level to really be comfortable what the data is. And if we don't have a common understanding across departments, across teams, then really taking the time to invest in collecting that data at an organizational level so we're able to solve the right problems, we're able to leverage the right capabilities, and we're able to measure how effective our solutions are. The quote that I have on the slide, we present this report with heavy hearts and take a moment to recognize and honor the individuals whose lives were tragically lost, is from the Arizona Maternal Mortality Review Committee in the report that was just published earlier this year, 2024. It covered the reporting period from 2016 to 2019, and most of the data on this slide is from the report, which was published by the Arizona Department of Health Services. Again, it's a new report. It stops before the 2020 period, so it'll be really interesting to have visibility of what the most immediate years look like. There are different definitions in how maternal mortality is measured: pregnancy-associated maternal mortality and pregnancy-related. Pregnancy-related maternal mortality is directly related to the etiological and physiological, pathological conditions that are present in the maternal continuum, and that's the pre-pregnancy journey, intrapartum, as well as postpartum. So pregnancy-related, again, directly correlated with obstetric events and with obstetric etiology. Pregnancy-associated is a larger condition. This is referred to as the universe of pregnancy-related mortality. And the way this is measured is any condition, so the numerator changes here, any condition that happens in the year that follows a pregnancy as well as delivery. So you can see, it's a much broader concept. Most of the data that we see being reported on is being reported on a pregnancy-associated level. So it is important, to be able to drill down into deeper levels of understanding of the data. So the timing of pregnancy-associated maternal deaths differs from intrapartum to pre-pregnancy, post-pregnancy, as well as to what happens in the 6 weeks after. 40% of maternal mortality is happening in the US in the 6 weeks after birth and backwards from that point, while 60%, the vast majority of maternal deaths, at least in the pregnancy-associated definition, are happening thereafter. And then another definitional aspect, which is what are the common causes? So when we get to pregnancy-related data, so that's the smaller subset where there's the direct linkage, mental health conditions play a very significant role in the space of postpartum depression and very severe depression that might lead to suicide. A fifth are cardiovascular conditions that are related to maternal mortality, and then close to a third of those, both postpartum hemorrhage as well as infections, including complicated infections such as sepsis during an intrapartum event. So I want to speak just a little more about data, and again, speaking about the definitional categories of data, and now getting into disparities. So these disparities that we talk about in maternal outcomes in the main happen across race and ethnicity, but they don't stop, which is what the picture on the right is demonstrating on the slide. In Arizona, this is Arizona data. In Arizona, African-American women and American Indian women have a disproportionate burden of disease. And this is regardless of how the data is diced and sliced. This is an incontrovertible dynamic in the state, but also at national level. In Arizona, there is certainly geographic discrepancies in maternal mortality. I think, it's important to point out here that I've centered the data, at least on maternal mortality, not on maternal morbidity, which is a much bigger spectrum of adverse outcomes. I want to go back to the slide for a moment because, I neglected to raise a very, very important point. I quoted how the report started, that these are individuals whose lives are being lost. Approximately 71 pregnant or birthing people will lose their lives every year in Arizona. That number went up. That's an average number. That number in 2019 went up quite significantly. It was 149 women who lost their lives in Arizona. 87% of the deaths are preventable. And in all of this are really interesting dynamics, right? So what's the numerical number once we get through the percentage? What's the disparities? What's the timing of pregnancy deaths? And that's really important because, again, it influences where the intervention points should be for organizations. Every one of us will have a different leverage point about where we might where we may need to intervene and where we would have the greatest impact in the timing. What conditions, clearly for clinicians, how these conditions are stratified is very, very meaningful. And then getting into disparities, which is a much wider discussion than all of us on the call today. I want to raise just one other point around the data and this common understanding. Just this month, in April, a study was published, and this actually made its way into mainstream media. And it was a study that was quite a detailed analysis of how maternal mortality is reported in the US. There have been some methodological changes around how maternal mortality has been reported. And what the study attempted to do was to understand what was the materiality of those methodological changes. And again, those are methodological changes, right? So, how many women are dying or being hurt from adverse outcomes, that remains. But how we're capturing that might have very significant bearing. And the study did find that the methodological changes that happened in 2003 and continued all the way into 2017 did have materiality in how maternal mortality is reported, and significantly so. One fact, though, that remained in the study was that the disparities that are prominent, African-American women remained at very significant, that disparity that we see remained in the study. So I just wanted to raise this point. I imagine that the study, it's just been released, will garner enormous attention, and perhaps a couple of months down the line, we'll have a better understanding of what the study actually means in terms of the data that we are seeing. So getting into the recommendations. And the recommendations in the report, in the Arizona Department of Health report, are stratified. It's stratified by quality of care interventions, which are mainly within the domain of healthcare systems, health coverage, which is where certainly the regulatory environment, as well as payers and employer groups, play a very significant role. Access to care, policymakers with access to care, as well as providers, have enormous responsibility for improving access to care. And then very important prevention and awareness, all within the domain of the healthcare systems. Health literacy and education, this shifts a little more into, and gets into the patient space around involving patients more through mechanisms for health literacy and education. So this is a great framework. It's extremely synergistic. Each of these rows are complementary to each other. It's not overly complicated. It's completely intuitive. And that's the best kind of framework, right? That's something that's already intuitive. It seems like it's common sense. We wouldn't argue with this framework. So let's see how this plays out in terms of the solutions for healthcare. And I'm going to talk just about a couple of case examples. And really the essence here would be this goal, this extremely aspirational goal to move that number from 71 to 0. If a death is preventable, then even though 71 might look like a small number, it means that we had, as healthcare providers and payers and employers and advocates and policymakers, we had 71 opportunities to prevent a death. And the death is the most significant outcome that any healthcare system around the world can measure itself about. So 71 opportunities every year where we fail as healthcare systems. So the Leapfrog group, I want to talk a little about data solutions. And there are an infinite, probably, number of data solutions that we could speak about on a call, but I want to flag just a couple high-level ones. Leapfrog is a group that advocates for patient safety in healthcare. They were formed in 2001 after the Institute of Medicine's report to Err is Human, which remains seminal in healthcare, was developed. And they are funded by employer groups, and their main focus is on transparently sharing data. And they have what's called the Leapfrog Hospital Survey, covers close to 3/4 of hospital beds in the US, and they benchmark the data, and they report at a public level. They've been reporting on maternal measures now for several years. And based on a couple sentinel measures, 3 of which I'm showing on the slide, they have designed programs working with many others across the United States to improve those measures. Their most significant improvement has been on the rate of early elective deliveries. Early elective deliveries, where those are often induced, have significant knock-on impacts. They lead to a higher cesarean rate often, and that has implications for maternal morbidity as well as for maternal mortality. So Leapfrog, as well as partners around the country, were really significant. And this to me is really, it really is the potential of what's possible from knowing the data, sharing the data, being constructive about the data, not getting our backs against the wall about what the data is showing. In 2010, when the data was first released and the number of early elective deliveries was around 18%, they could have been well, we're not going to do anything about this, or the number's not too bad, let's compare ourselves to OECD countries on that particular measure. We don't look so bad. But there wasn't that, there wasn't that positioning, there wasn't that approach that was taken. Instead, it was a very proactive, very enabling, multi-stakeholder approach that drove that number down to almost zero when it was captured in 2023. Again, I think a real world example of what's possible from using data very, very smartly and using data very, very constructively and collaboratively. This is another example of data. This is from Press Ganey. They're a commercial organization, so they're a private organization. They report on patient experience. I've often used this slide because it's so dramatic. I showed earlier on that a significant, close to 30% of women of maternal deaths will happen during that intrapartum period or immediately thereafter. So what the slide is showing is the difference in patient experience scores, maternal patient experience scores, compared to all other races. So it's African-American women and how they are rating their experience in hospital, meaning during the time of delivery, compared to all other races. And almost in every single category, and this is consistently, Press Ganey shows this longitudinally, every year it looks quite the same. African-American women rate their experiences worse. And perhaps we could stop at that point and discount it and say, oh, well, patient experience is about rating the environment or, rating respect. But it would be lost value if we stopped at that point, because what we're trying to solve for is, why is this discrepancy there? Why does this variation exist? Why are African-American women more vulnerable? If we want to address that dynamic, then every data point becomes important. And certainly we do not have a lot of data points around what patients are saying to us about their experience through their healthcare journey. So instruments like patient experience surveys become extremely material because they allow us to bring the voice of the patient. And there are very few validated instruments for patient safety in the maternal journey. So Leapfrog has been sharing this data with their constituents for several years now. They've gone further. They've developed conscious bias training modules. They work with the hospital groups that share this data in a partnership. So it's not just sharing the data. They give the data back to hospitals. They give them enablers, and then it becomes to the providers and their appetite of what they want to do with the data. I want to talk a little about pathways for care. So this is clinical. This is a clinical pathway that's been developed by AIM. This is an agency for innovation in healthcare improvement. They operate across states at a national level in the US and very, very highly regarded, often partnering with the profession in the US. So they have implemented bundles, and the bundle that is being demonstrated on the slide is that for hemorrhage, postpartum hemorrhage, which is a very common adverse outcome in pregnancy, and one that's preventable. So, in 2024, we ought to be able to, as healthcare systems, be able to detect who is vulnerable to postpartum hemorrhage or even an intrapartum hemorrhage and take steps to doing that. The challenge is that there's enormous variation in how we standardize evidence-based pathways. It's not that we do not know what evidence-based pathways are. The challenge becomes how we standardize those at provider level. And that's what a bundle is. It's a consistent, highly reliable, highly wired process that leaves very little variation in how the pathway is followed. So there's very little room for bias, for all, for other dynamics to come into a pathway. It's entirely rules-based. And if it's built into the electronic record, that's even better in terms of how the rule is implementing. So AIM has started with the hemorrhage bundle, and it is their intention to move to hypertension as well as to the other commonly occurring conditions that contribute to maternal mortality and morbidity. Payment systems in the framework that I just showed very, very significant as well in terms of aligning incentives. Payments, we could have an extremely well-coordinated pathway, but if we do not have teamwork within that pathway and we do not have incentives and payment systems aligned with that pathway, that's very significant in terms of reducing the value of pathway. What we really want is alignment across all of these solutions that we are describing. So how we pay for maternal care, and this is the example from the Dutch. They recently were awarded Best Abstract at an international outcomes conference for what looks like quite a simple structure. It's an episode fee made up of several different payment bundles set at the prenatal journey and covering the intrapartum as well as the post-natal journey. We implemented something exactly like this in the organization that I previously worked at Discovery Health, in collaboration with the obstetricians. And when a payment model like this is complementary or it's designed alongside a clinical pathway, it becomes quite an effective way of aligning incentives and raising visibility of outcomes if a model like this is linked to outcomes. Digital solutions, which we all want to talk about, and there is a plethora of digital solutions. During the pandemic, we saw even more solutions and interventions come our way. Many of these have to do with remote monitoring. With AI right now, the focus is mainly on data and big data sets. I'll speak about that in a moment, but also on remote monitoring. And what the slide is demonstrating are small examples. These are not mainstreamed in any way, but these are being implemented across the world. Many of these are US-based interventions, and there are several different categories that these interventions for remote monitoring are commonly being implemented on. The three most common are blood pressure monitoring, and what's happening in obstetrics is mirroring what's happening in the non-obstetric clinical conditions: fetal heart monitoring and gestational diabetes. The point I would make about this slide, exactly like payment systems, is that as innovative as these are, there is still enormous challenges around who has access to these. Where is the data going? Are the people who are receiving the data empowered? Are there operational pathways and standard operating procedures for alerts to trigger an action? Who's in the home to monitor some of these measures? Clearly, the remote monitoring reduces the need for monitoring, especially high-risk patients in the home, but doesn't remove the need entirely. So who is available to support patients? But the reason that these are really, really exciting is because they allow a high-touch intervention. Pregnancy is very unique in the sense that patients are working through, and it's an emotional time. It's a time of enormous expectation, but it's a 9-month journey, and then it continues after the journey. So there's a period of time here when patients are in healthcare systems, they're out of healthcare systems. With devices like this, they allow patients to remain connected with their providers almost continuously if we use these devices well. And then just a last example, and this is an example, another application of AI. So I mentioned technologies and how AI is being used through remote monitoring, for example. But AI, a second application for AI, is using the data for predictive models. So determining who's at risk. So this is, again, a predictive model. A condition hasn't set in at that point. Eclampsia, for example, has not set in. But what this kind of model does, and it's not only Stanford's that's doing it, it's just that they were one of the first to develop a model, is that it aggregates enormous amounts of data, which is what AI is very good at doing, and is very nuanced in terms of allocating a predictive score for a patient, and then allowing providers to manage that score in a very proactive way to prevent the onset of a complication. Exactly like what I was talking about earlier, this initiative is really as good as everything else that it's linked towards. If a patient doesn't have access to a score or doesn't have visibility of what the score means, then we're missing 50% of the participant of the journey, if not more than that, right? So that becomes enormously material. How do patients get their scores, and how are patients educated about what their scores are? How are these scores How are these scores iterated on throughout the maternal journey? We don't want these scores only at the time, of a 3-day event when a patient's in hospital delivering, but can these scores be there from the time that a patient comes into a maternal journey or even before, and remains during periods of vulnerability once the patient leaves the healthcare system? And I'm using the word patient, pregnant women are not patients. Most people have completely uneventful deliveries, but today our focus really is when things go wrong. So how we use data and smart ways of using data and integrated ways of using data are extremely important in the maternal journey. And I think we're going to be seeing such a lot of excitement in this particular space about the data. So I'll end by reaffirming the point that I made, that these are terrific solutions. But what is extremely important, that we have coordination of the solutions. We do not want fragmented solutions. The powerful solutions that are not coordinated, that are not brought together, and even that framework that I showed that had the rows. Ideally, we don't want those rows. Those rows are there for the purpose of articulation, and they're very meaningful. But essentially, we want a picture where they're not rows. We want all of these to be blended strategies. Really difficult to get to that. But unless we have real cohesion and coordination, then these solutions will not be as effective. And the reason we can say that confidently is because this is not the first time in 2024 that we're talking about maternal solutions and maternal health innovations. We have been talking about this for decades, and yet we have maternal outcomes and we have disparities in those outcomes really stubbornly resisting those innovations. And that really ought to be a pivot for us, which is, why are those innovations that we already have not working? Thank you so much. I'm really happy to take